I'd like to thank you all for joining our call with Dr. Ziv Peled, and we're looking forward to sharing this great information with you as sort of a pre-conference webinar. So, Dr. Peled, would you like to begin?
Yeah, thank you very much, Dana, and thanks everybody for joining us. Yeah, we're going to talk very briefly today. The sort of format for this is I'm going to just introduce a few of the concepts that I'll be talking about specifically with regard to the use of adipose-derived stem cells and nanofat, as well as microfat for neuropathic pain relief. We'll talk a little bit about the cadaver lab that we're going to have related to this toward the last day of the course. And then we're going to kind of just mention some of the other great things that you'll hear about and get to learn about if you come to the whole meeting itself. So I'm a plastic surgeon initially by training, but then just as I finished my plastic surgery training in Boston, ended up doing a peripheral nerve fellowship, and a large portion of my practice, which is somewhat unusual, I guess, for plastic surgeons, focuses on patients with some aspect of chronic pain. And as many of you know, this can be a very challenging thing to treat, and is also one that is incredibly rewarding and is one that has a huge need that really can't be understated. This slide is one of my favorite because it really speaks to the fact, and this is a study out of Lancet not that long ago, it's only 4 years, that chronic pain affects anywhere from 20–50% of the population, depending on which studies you're looking at. And if you can imagine what that would mean in the US alone, you're talking about 75 to 150 million people just within our borders, not to mention worldwide. There are general kinds of nerve injury and things that can cause pain. There's the nociceptive or tissue injury component of it, the neuropathic, which is the direct nerve injury, and the nociplastic, where you have a central sensitization, a sensitized nervous system. So even though the initial nerve injury may have been digital nerve transection, when untreated and left to foment for many years, in some cases decades, the whole central nervous system gets sensitized to any input anywhere, and now you have a much bigger problem. With respect to fat grafting, we'll be talking about, and you'll hear about, the history of fat grafting. And I think this is always interesting because where we're at and where we're going really has a lot to do with where we have come from. And so we talk a little bit about where fat grafting first began over 100 years ago, but was used intermittently until it was really refined as a technique, mostly for volume enhancement by Sid Coleman in the 1990s, but has very rapidly evolved since then to not only become more consistent with respect to volume, but in recognizing all of the wonderful changes. For example, when you are injecting fat to reconstruct a lumpectomy defect or to reconstruct a small breast that the patient doesn't want to have an implant placed for and a flap is too much for. And you realize that aside from providing volume, when you inject that fat, it really gets rid of all of the radiation, or much of the radiation damage from the radiation that has been placed on that breast. The whole idea that there are incredible regenerative components within the fat that we're grafting that began to first be recognized in the 2010s. So that's now 15 years into it, and that has really exploded. So we'll talk about the stem cell component of the autologous fat grafts that we're putting in, what the difference between microfat and nanofat is that you can see in those two syringes. Exosomes is a word people hear a lot about, but it's really related to a lot of the cytokines that these stem cells release, and that is contained within the microfat and the nanofat, and how you can combine PRP and stromal vascular fraction autologous fat to really optimize your results. The idea of using adipose-derived stem cells and fat for neuropathic pain has a very strong biologic basis, and one that continues to grow. We know that these cells secrete exosomes that counteract the inflammatory neuritic cascade, for example, and we'll have many more examples if you come to the course. You have decreased expression of inducible nitric oxide synthase and COX-2, IL-1, TNF-alpha, and all of this is produced by the cells contained within the fat that you're grafting. And so this, as this study is just as a teaser, showed that it can actually improve the pain that rats feel in their paws after a burn injury. And this is just one example of the animal models in which fat has actually been shown to reduce pain. And we'll obviously examine more of these in greater detail, but also delineate a lot of the human clinical trials, since presumably many of us are not treating animals in a lab as a significant component of our practices. But there's plenty of data now in all sorts of clinical scenarios, whether it is post-amputation pain, post-mastectomy pain syndrome, headache surgery, where this has been applied with good effect. And I think as previews of the remix, so to speak, I always like to think about, again, where we've gone, but where we can go. I think the idea that we can harvest fat and become facile with its use and understand how it is doing what it's doing will really allow us to do more and more and more things. And you'll hear about that in this conference. So for example, obviously aesthetic purposes, not only for volume enhancement, but for skin quality rejuvenation, for improvement in sexual function, incontinence, joint disorders, and other musculoskeletal pathologies, hair loss. The list can go on and on. I think it's really interesting to think about, and how we become facile with fat will allow us to maintain our positions in the forefront of bioengineering and tissue engineering. And when I presented this last year, it's remarkable how things progress quickly. I had literally just spitballed the idea that at some point, and I do a lot of breast reconstruction with my wife, and we do a lot of neurotization for that. But the idea that you could actually ultimately harvest somebody's own fat, seed those adipocytes on a biologic scaffold, grow and expand those adipocytes, those fat cells within that scaffold, so that you don't need to liposuction 5 liters of fat. And once that construct is ready to be implanted, it actually gets transferred into the patient as a breast tissue made up of, or as a breast made up of their own fat. This has now actually been done and published in a very small series, and without a doubt, I think represents the absolute future of breast reconstruction, to the point where I think it actually, not to be too glib about it, but should be scaring Allergan and Motiva and Mentor, because their products may no longer be necessary in this regard. I think there's also the idea of tailoring the fat based upon what the patient needs. So for example, there's a lot of studies ongoing where we talk about, and we'll discuss these in more detail, where fat harvested from the inner thigh versus the lower abdomen versus the flank or back will have a different secretome cascade and different genetic and biological markers, which may optimize that particular store of fat cells for use in neuropathic pain versus volume enhancement versus skin rejuvenation and so forth. And I think for the surgeons out there, if you've ever seen a nerve, a lot of times when you have nerve compression here is a low power on the left and a higher power on the right. This is the common peroneal nerve on the outside of the knee. You can barely actually see the nerve bundles themselves because there's so much fat around it. And the point for this is that when nerves are injured, the body loves to put fat around the nerves to help cushion them and heal them. And that is what we will be showing you how to do, so that you can treat the discomfort straight away yourselves without having to wait the years that it takes for that to happen. We'll talk a little bit about how this can be used in a post-mastectomy setting. So this is just some of the limitations that we have with regard to current nipple-sparing mastectomy techniques as regards to sensation. And so my wife and I have pioneered and now have the world's largest experience with hundreds of patients in preserving sensation or restoring sensation with nerve grafts. But even if you look at this, while our results are pretty good, this is where patients start, where 85% of people have excellent sensation on this one particular outcomes metrics, and basically there's 9% who have good and a very few that have poor or little sensation. Within a few months, which is to say about a year, we are able to bring a lot of that back. So we have basically over 80% of patients are in the good to excellent sensation range, but we're always trying to find ways to improve that. Why don't we have more patients in the excellent range? Why do we still have 6 or 11% of patients in the fair or poor range? And again, I think this provides an interesting opportunity for potentially use of fat to augment the nerve regeneration and the nerve function that we're seeing. So we'll kind of spitball ways to think about that, perhaps in patients. This is a study demonstrating the effectiveness of fat injection for treatment of recalcitrant migraine headaches. And I'll present my data, which have basically very similar, slightly better numbers in quite a number of patients. And then, of course, we will show you exactly how I harvest as part of that cadaver lab on Sunday, how I like to harvest the fat, how I like to process the fat, and then, of course, using ultrasound guidance, how I like to inject the fat. And we can do this. We will have specimens from all over the body. And so we can talk about things like recalcitrant headaches, whether it's the supraoral, supratrochlear, auriculotemporal, zygomaticotemporal, greater lesser third occipital in the back of the head, to perhaps even persistent ulnar nerve neuritis at the elbow. We can talk about dorsal radial sensory nerve trauma, which is actually fairly common. We'll be able to have access to some lower extremity and torso cadavers, so we can talk about inguinodynia, which is to say chronic groin pain, neuralgia paresthetica, which is chronic thigh pain, lower extremity further down, common perineal, superficial perineal, deep perineal. We will have the ability to ultrasound these, inject them, and then we will try to cut down on these specimens and see where we've injected the fat in comparison to where the nerves are actually located, so you can literally see the handiwork that you've done to see how close you came to the target. And we'll have other options if people are interested, as we'll have access to multiple body parts for trial and error. And so whenever I think about adipose and nerve, initially it seems like an unlikely pairing, but the reality is that they really are incredibly compatible for reasons that I hope to convince you of further at the time. And so this is our conference. Feel free to scan the QR code there. You can save $200 with that little code at the bottom, Peled 25. And yeah, thank you for your attention. We really hope to see as many of you there as you can. And please keep in mind that the lab space is limited to probably about 8 participants and is actually filling up fast. So if you're interested, please sign up soon so that you don't have to miss out and wait until next year. Thank you.
Excuse me.
For your
Oh,
time.
sorry,
Yeah.
Dr. Pellet, I had a question for you.
Mhm.
You were talking about some of the other areas of the body. And have you had the opportunity to work with any orthopedic surgeons? Because we're inviting a lot of orthopedic surgeons to participate in this. And it looked like there were some wonderful studies or things that you've worked on in that area of the body, the knees, the legs, that kind of thing.
Yeah, so there's a huge it's the largest orthopedic group in San Francisco, is now routinely referring me patients, and their foot and ankle surgeon, once all the musculoskeletal things have been either addressed or ruled out, I see quite a number of patients from him for all sorts of tarsal tunnel, deep perineal, calcaneal nerve issues, which again we'll be able to image, hopefully with ultrasound, inject and dissect to demonstrate the anatomy for people, so they can see what it is that they're injecting and what it is that they saw on the ultrasound image. The busiest orthopedic spine surgeon in that group sends me patients with occipital neuralgia fairly routinely. And there's even things like notalgia paresthetica, where you have sort of random mid-back hyperesthesia that many people don't know what to do with. These are all things that I think are amenable to potential treatment in a conservative fashion, first with fat, before necessarily running to surgery. So if there are orthopedic surgeons there, of course, post-amputation pain is a big thing that people have to deal with, and it's something that I see a lot of. And there's lots of ways to manage that surgically, but if you can do a more conservative approach, especially someone who's had attempts at nerve reconstruction that have failed, and clearly perhaps they are what we call neuroma formers. So no matter what you do, when you touch that nerve with a scalpel, a neuroma will form, just like a keloid often reforms at the skin if you cut it out. Perhaps fat is a good option for them, and I think is actually there's a couple of studies now ongoing that haven't been published yet, but that I'm aware of, looking at fat injection in the skin to treat keloids, which is a huge worldwide problem, especially in African American, Latin, and Asian populations, which tend to be Middle East as well, tend to be darker pigmented. So long-winded answer to your question, Dana, but yes.
Well, it sounds like anybody would benefit from coming to this course if they were interested in pain.
Yeah,
So,
I mean, I think the reach truly is remarkable, and I think that there's so much of that 20 to 50% of the world's population that have pain and it's chronic pain, remember. So that means that by definition, assuming, and it's a bit of an assumption, that those people have had access to reasonable health care, that people haven't been able to figure out. And I think there's my favorite saying from my training time at Harvard was one of my professors at the Shriners Hospital used to say, Ziv, you have to be able to see what you're looking at. And in fact, my sister, who has done Ironman 4 times, she's got a really high level coach, obviously, who also was a Division I runner in his day and age. And I did an operation on her knee to fix a nerve that the orthopedic surgeons scoped and looked at and couldn't find. And she was quitting Ironman and then went on to do 2 more. When I finished with her, her orthopedic surgeon, or sorry, her coach has now had 2 orthopedic surgery procedures and clearly had some kind of structural issues, but still has the same initial pain that he had before. So the instability is gone, but the pain remains. And it's identical to my sister's pain. And so what everybody assumes must be an issue with the ligament, a tendon, or bone is actually an issue with a nerve, and is amenable to an easy diagnostic injection, and then ultimately perhaps a quick fix that has been surgery up until now, but may be amenable to fat.
Jacob has let me know that there are some people that would like to ask questions. And
Sure.
Jacob, do you want to unmute yourself and let people know how they can participate in the question asking?
Sure. If you guys have a question, you can feel free to put it in the chat box. We had 2 people send in questions. One was, given the combination of autologous fat, scaffolds, and growth factors, how are these composite constructs typically classified from a regulatory standpoint,
Yeah,
especially under the FDA's HCT P351 pathway
Sure.
or the other?
Yeah, that's a great question. And I think the first one is in terms of fat, the nice thing about fat, the way it's manipulated now in terms of conversion of the microfat that you would actually it's part of your lipoaspirate, and the very mild mechanical manipulation that is required to convert that microfat to nanofat, that is still classified as minimally manipulated by the FDA and therefore is clinically usable. Once you start to do things like add scaffolds, growth factors, etc., and I have yet to do combination therapy, but there are people that will present at the conference that have. Those things are done and are very strictly regulated by the FDA, and usually they're under some kind of research protocols. But I think, and I think scaffolds certainly are that, okay? But the nice thing is that there is a reasonable amount of data that shows that just the minimally manipulated fat, meaning nanofat, is often as effective, and certainly has been in my chronic headache patients, as a lot of these combination therapies.
Thank you. Get another couple. First one, is the workshop, is that a hands-on workshop or observation only? I don't know, I guess, could you go into more detail about what
Yeah,
activities you
so
expect?
yeah, we're going to have several specimens: heads, arms, legs, torso. So my vision for that lab is that, let's say we have a head, I will be able to show people how I would ultrasound, and we will have ultrasound scanners there that are, my understanding is being provided by one company. I won't say which yet, in case we switch at the last minute, but we'll have ultrasound scanners so people can learn how these nerves can look on a cadaver head, at least. And I submit to you, if you can ultrasound something on a cadaver, you'll much more readily be able to do it in a live human being, where it's a lot easier, and you'll be able to position them a little bit more effectively for your purposes. We'll then show you how to harvest fat, inject the fat. And then my thought was we could cut down on those, because I do a lot of surgery on all these nerves that I'm planning to demonstrate that you can inject. And we can see how close to those nerves we've gotten, whether we were too superficial, too deep, whether we hit it just right along this course of the nerve, but not in another course. So the hope is that it's going to be very hands-on, and we'll be able to do that in all parts of the body.
Cool. Another question we've got, can nurse practitioners perform minor fat transfers and knee fat transfer?
So I actually don't know that. I, at this point, do not have physician extenders in my practice. I still do all of my injections myself. But you know what? We are adding a nurse practitioner as soon as she graduates from her NP program in about 9 months. And so my initial thought was to have her just do a lot of clinical stuff and minor procedures, certainly injectables. And I will actually find the answer to that before the conference, and we'll be able to give you a more definitive answer on that when we meet.
And I think that's a great question. I think normally that's sort of done state by state based on the regulations of each state. And nurse practitioners have different licensing issues from state to state. So it'll be very interesting to see how this expands. And I certainly think that it will as the procedure becomes more mainstream. Don't you think so, Dr. Peled?
I do. I mean, I think if you, we do a lot of these procedures under strict local, occasionally with some inhaled nitrous oxide or a little bit of oral Valium in our office. And so while I don't know that it's, given those things, meaning the inhaled nitrous oxide or oral sedation, that you'll be able to be across town or operating. If you're on site seeing patients in another room, these are so safe that patients with the inhaled nitrous oxide or Pronox, they drive home 15 minutes after the procedure is over. So I guess the point is that while these procedures have a learning curve, while they have to be done very carefully and obviously safely, they will likely within a few years reach a level of involvement similar to that of fillers, which many nurse practitioners and PAs and APRNs do perform for a physician practice in the office currently.
So do we have any other questions, Jacob, or?
There's not any other questions in the chat. If anybody has any more, feel free to add it to the chat box on Zoom. Yeah.
Well, I feel like I know more about what's going to happen in July and August at the conference. So this is very, very helpful. And I'm looking forward to circulating this presentation to some of the people that are currently looking at enrolling. So I really appreciate your willingness to do this on a Friday afternoon. So we thank you so much for your willingness to do it.
My pleasure, guys. Thanks all for coming.